Can you hear me? Okay. I hope everybody got the link. I only sent it to the 2 batch reps. Okay. Since it's already 2:30, did you all have a lecture before this? Okay. So there was a break in between, so that was good. Do you have lecture after this? Okay. Then probably we'll have to start then. But I think your batch is also around 200, right?
Yes, madam, but today there's heavy vaccination going on in the faculty for our batch.
Right. So no one has collapsed or anything, right?
No, madam. I think
some are held up there.
Yes, madam.
All right. Okay. So should I wait or start? For the 1 p.m. lecture, how many were there?
Around 50, madam.
So out of 200, only 50. Is the batch rep here? Is the batch rep here? One of the batch reps?
I think they are both in the faculty.
Okay. This is a new lecture which we introduced to you all. You know that you're in the new curriculum. There you're going to learn the pathophysiology, so applied physiology, pathology and pharmacology first of the cardiovascular system, and then with the clinical sciences stream, you will learn the clinical application, right? So for y'all, in this new curriculum, we thought of including this new lecture on interpretation of ECG in acute coronary syndromes. I believe you just had a lecture on pathology, lecture on ischemic heart disease. Am I correct?
Yes, madam. It was just before this.
Yeah. So we thought it will complement that because you need to know how to interpret an ECG, because before you get the clinical lectures from the clinical medicine department, you will have to undergo a clinical medicine appointment. I believe as of yet, you all have never been exposed to ward setup, no? Have you gone to wards and so on? No?
We started last week, madam.
Medicine appointment, is it? Medicine and surgery. Wonderful. So you all are lucky because last time when we ran CGS module, no one had ever seen a patient. So at least this time you will actually see patients with the ECG changes, and you will naturally want to know what's going on. So we'll just start, let the others join. As for reference, now I believe everyone has access to Ganox, right? So just start with Ganox, just 1 or 2 pages, the intro into ECG. And I believe you all have a copy of ECG Made Easy. Yes or no? Okay, so share it with everyone, those who have got. And the other thing is, please, are you all referring to cardiovascular examination techniques in a Hutchinson's or MacLeod, some clinical examination book? Okay, at least one is doing, so that's good. Some students have never heard of that book, so I'm glad somebody has heard of it. And Command Clark is the other book you all are reading, I suppose, is it?
Not yes, yet. Madam.
Okay, right. So although we have sort of giving it pathophysiology, pharmacology, and then clinical, since you're going to clinical, you're learning clinical, you're having clinical training at the same time, you can nicely complement it and learn the clinical examination, history examination as well, right? So we'll start off. I think there's more than 50. I think that's a good thing. So for this new lecture, we thought we'll revise the structure and function of the conduction system of the heart, discuss the pathophysiological basis of ECG changes in acute coronary syndrome, describe, let me start recording first.
Recording in progress.
Okay, so today we are going to learn about interpretation of ECG in acute coronary syndromes, and the learning outcomes are, first of all, this is, you revise a bit the structure and function of the conduction system, as well as how you take ECGs, and discuss the pathophysiological basis of ECG changes in acute coronary syndrome, and describe ECG changes in relation to coronary anatomy in acute coronary syndrome, and discuss use of pattern recognition in interpreting ECG in acute coronary syndrome. Right. So pattern recognition is important because we are not experts in ECG, not you, not me either, right? So I'm just a physician. I'm trying to see how well it correlates with my patient's symptoms and signs, and what can I do best for this patient's management by interpreting this ECG. So we don't need to sort of analyze each and every detail in the ECG. That's for the expert. There are electrocardiophysiologists who does that. That's a branch of cardiology, and they will help if you run out of options, right? So basic pattern recognition is what we need to know as students, as interns, and then to make sure that we are not missing any major pathology. Okay, so just to revise, this is the conduction system of the heart that you know. You have already learned this in anatomy and physiology. The sinoatrial node is the primary pacemaker, and there are intermural pathways, then AB node, and AB bundle or bundle of his, and bundle branches left and right, and the Purkinje fibers going into each ventricle. Okay, so if you can revise what you have learned in physiology, how the pacemaker potential is generated and it spreads through the atria, and how it goes through the bundle. So depolarization in healthy hearts initiated in SA node, right? But if the SA node is dysfunctional or diseased, especially in elderly, the AV node can take over, or any other pacemaker tissue has the potential to take over, but obviously the rate will be slower, right? So it initially spreads radially through atria. Atrial depolarization completes at 0.1 seconds and converge onto the AV node. And AV nodal conduction is, it's lower than the XA node. So there is a natural AV nodal delay, right? And the wave of depolarization then spreads from the top of the septum through rapidly conducting Purkinje fibers to all parts of the ventricle, right? Then the ventricular depolarization starts from the left septum to the left of the septum and spreads to the right. So that is something you have to remember. And then it spreads down to the apex and return to the AV groove and proceeds from endocardial to the epicardial cells. So the way it spreads gives us clues when we are interpreting ECG, right? These are not new things. You have already learned how this is happening. Now, in the next lecture, we'll discuss about the arrhythmia. So you need to remember this bit for that as well. Okay. So this is how the normal ECG being taken, and this you did for the physiology practical, hopefully. At least you got the demonstration, no? Because of the restrictions, we didn't have individual sessions, if I'm not mistaken. Did you get this practical? ECG?
Madam, the video was uploaded to refer.
Okay, right. We didn't have a on-site session, no?
No other at that time.
Okay. So you all are at a disadvantage, but since all of you all are doing a clinical appointment at the moment, when the ECG technicians come and do ECGs, please have a look. Take permission from the patient. Please be there and learn. Because as a student, you don't have to only learn from the doctors. You can learn from others a lot. Nurses, ECG technicians, physiotherapists, anyone. You can learn a lot, right? So be very humble and learn from others, because that pays off. Because every doctor should be able to perform an ECG in an emergency. You don't wait for the ECG technician, right? We have this habit when the patient is having severe chest pain. You know that it's an MI and you're blaming the ECG tech not here. But that's not that person's job to come running to do a ECG. You have to, if you think the patient is at a danger, you should be able to do an ECG. So 12 lead ECG, you need the machine. But if you don't have the machine, do you think is there any other equipment in the ward with we can perform, we can get a reliable ECG strip? Anyone? What is the other equipment in the ward that you can get an ECG from? Anyone? Let's see if there are any students that I can remember asking names. No one. How do you manage emergencies in a ward? Has anyone witnessed an emergency in a ward? Cardiac monitors, yes, you can have a look. If the patient is on a cardiac monitor, yes, lead 2 will be visible. You can have a look, lead 2. What else? Have you seen an equipment called defibrillator? No. There's an emergency trolley which is always covered with a cloth. You didn't bother to have a look. Now, tomorrow, are you going to clinicals or are you going to take off because you had the hepatitis B injection? Sick leave. Who's going to clinicals tomorrow? Anyone?
Yes, madam, we are going tomorrow.
Thank God. Okay, Tarishi. So if you are going, at the nurses station, there's an emergency trolley, right? So just with the permission of the nurses, just open it up. See, there's an equipment called defibrillator. There are 2 pads. I think if you have watched dramas, medical dramas, what is Dr. House or ED or whatever, you would have seen defibrillation. So with that equipment also, you can obtain a ECG. Just keep the 2 pads and you can monitor the ECG waveform, and even you can take a printout. Okay. So everyone should know. So if you're keeping the defibrillator, it will be the infraclavicular right side and just below the left, just beneath the apex card. But to take a standard ECG, you need the 3 limb leads and the chest leads, right? So I'm not going to go through this because this was in Canon and you have learned a lot, and you're taking these limb lead measurements 1, 2, and 3. So 1, is it a positive deflation that you're going to get in the ECG or a negative one? 1, lead 1, lead 1, 2, and 3 all will be positive, isn't it? Why? Because heart is here and the bulk of the muscle is towards the left. So there's an arrow going into this direction. So that is the deflation you're going to get, which is towards the leads, that is positive. right? Similarly, 2 and 3, right? If it is going away, then you get a negative deflation, right? And how are we going to capture right arm, left arm, and left lower limb, and the 6 limb, chest leads? But sometimes you can have additional leads on the chest, on the posterior surface as well. So I'm sure you're familiar with the unwoven triangle, right? 1, 2, and 3 limb leads. So we, you have learned this in your physiology days as well. We look at the cardiac vector or the normal cardiac axis, right? So that's what I said. Lead 1, that is the combination of these two RA and LA leads, it's towards LA. So it's a positive deflation because it's coming towards the lead, and it is marked as a positive deflation, right? Similarly, lead 2, RA and LF, summation, and it's also going through LF. So left foot, or in other words, it's coming towards the lead, and it is also a positive deflation. And the third one, between LA and LF, again towards the lead, and it is if it is going towards LF, it is negative, and if it is going towards LA, it is positive. So generally, all 3 leads can be positive because this third limb lead could be either shifting to this direction or this direction, depending on the muscle bulk, right? So how do we calculate or diagnose if there is any deviation, right? So if there's any deviation, that means the one part of the muscle bulk is prominent, and that takes up a lot of electrical activity. For example, left ventricular hypertrophy. Now here, see what has happened. In the first limb lead, it is a positive deflation, but the second and third, it's negative. Let's go back. So if it is negative, then it's going towards the other side, isn't it? Opposite deflation. So it's the left side, you know, the heart is not in a single plane, it's more towards anteriorly. So left ventricle takes up a lot of muscle mass, and that is the reason why the second and third leads are negative, right? Let the right axis, if this is negative, it is towards the right side. If the right ventricle or right side of the heart is hypertrophied, the vector moves to the right side, and rest of the 2 deflations are positive, right? And that is right axis deviation. So just by looking at the first and the second, we can so first, second, and the third limb leads, we can get an idea whether it's deviated or not. So when we talk about the pacemaker tissue, the SA node and AV node, we know that vagally it is vagal stimulation decrease the firing rate, sympathetic stimulation increase the firing rate, and AV node is continuous with the bundle of His, and the left bundle branch at the top of the interventricular system continues at the right bundle branch. There is the left bundle branches at the top, and the rest of it continues at the right. The left always divides into anterior and posterior fascicles. So if one of the branches get damaged due to ischemic changes, then we have this morphological change called bundle branch block. So you know that usually there is an AV bundle. When the impulse goes through the AV node, there is a delay, right? And if, for example, if the right bundle is infarcted, there is a delay here. If the left bundle is damaged, there's a delay here. So what will happen is the QRS complex get widened, right? So in any bundle branch block, the QRS complex is widened. So that is a universal thing. But the pattern, the morphological pattern of right and the left bundle branch blocks are different. For example, right bundle branch block, the changes which we are going to observe are predominant in lead 1 and limb lead 1 and chest lead 1. So chest lead 1, we have the classical RSR pattern, right? So there are 2 Rs. And there is a widened S wave in lead 1. The left bundle branch block, can you see again, there's a widening of the QRS complex. There's a large QS or RS in the D1, right? So whenever you see a large or widened QRS complex, you have to suspect bundle branch block. There's some additional delay occurring here because ideally, although there's an AV nodal delay, it branches off and it depolarizes together. But if there is a block here, the depolarization has to go through here and then come here. So that is the difference that you see in these morphological changes. So what you have to remember is lead 1 and limb lead 1 and chest lead 1, we are looking for these morphological changes if there is widened QRS complex, right? So RSR pattern like a M, distorted M in right bundle branch block, and left bundle branch block, it's huge, it's really wide. So why it is important for us to identify this? Now we always talk about ST elevation, MI and so on, but a new onset left bundle branch block is indicative of acute MI and it is managed as ST elevation MI. So that is something you have to remember and you will later learn in your clinical lectures as well. So left bundle branch block, either the posterior or anterior, if the major branch is damaged, you get this widened QRS complex with large QS or RS wave here in the first chest lead and you diagnose acute MI, but that has to be a new onset one. Because once infarcted, then this bundle branch block pattern will remain in the ECG for life, right? There's a conduction delay and that will remain. But if it is new onset, for example, before the onset of chest pain, if you have a normal ECG, and with the onset of chest pain, you have a left bundle branch block, you take it as myocardial infarction. Okay? So this is in relation to coronary anatomy that you have already learned. There are 2 branches, right coronary and left coronary, and left coronary artery then divides to left anterior descending artery and the circumflex artery. So depending on the infarction, you have specific changes occurring in the ECG, and that you can correlate with the coronary anatomy. So now, although you will learn the therapeutics later on, you know that as therapy, we can do coronary angiography and stenting. You can directly put a dye from here and you can get the coronary anatomy. If there's a block in the left anterior descending, you can put a stent and open it. So it's very important that you diagnose the pathologies in the left anterior descending so that you can plan your, tell your cath lab people, get the correct size of the catheters and stents and so on. So primary ECG diagnosis is still valid because not all patients will be presenting to cath lab facility enabled centers. So it's very important to decide whom you are going to transfer and so on. Okay. So now we are going to move on to the ECG changes in acute coronary syndromes. Okay. So I will just let you go through the slide first before me talking. Just take a moment and just follow the pattern A, B, C, D and how it is evolving. I'll just give 1 minute. Okay, so what did you observe? Now, this is the normal electrocardiogram with the PQRS pattern, right? So we have learned this in our physiology days, and we know the intervals, the durations, why this is occurring and so. But when there is ischemia, or what we commonly call acute coronary syndrome, there are several changes that you need to observe or be mindful or look for in the QRS complex morphology, right? So one of the morphological changes that we are really worried is ST segment elevation myocardial infarction. You get the ST segment totally elevated, and this J point or the S, there is no S wave, downsloping S wave, so that is totally elevated. So this is a very important point to notice. If you had negative S wave then followed by some elevation, you are not calling it a ST elevation. It could be a J point elevation. Now J point is the isoelectrical point. In some patients that can be naturally elevated, but if you are not sure, patient is having chest pain, it's better to repeat the ST, right? So the typical ST elevation, you don't get any isoelectrical point here. You have the whole ST segment being elevated, and we'll see how it is happening. And of course, non-ST segment elevation myocardial infarction is still an infarction, death of tissue, but you get a ST depression, not so severe, but still the ST segment from the baseline is depressed, right? So it could be upsloping or downsloping, and there are several other conditions you think of when there's ST depression. But primarily, if the history is ischemic chest pain, by now you know what it is, left-sided central constrictive type chest pain associated with autonomic features, sweating, feeling dizzy, tachycardic, patient is scared, short of breath, that type of patient, if you see ST depression, that is indicative of myocardial infarction until proven otherwise, right? So non-ST segment elevation myocardial infarction, there are other changes like T inversions, and sometimes even without infarction, if there's just ischemia in our unstable angina, also you can get ST depression and T inversion. So how would you differentiate whether there's an infarction or just angina or severe ischemia? No death of tissue. Is there any test that you can do to differentiate these two entities, infarction and severe ischemia? Anyone?
Test for troponin levels?
Yes, troponin levels. I'm sure you had the lecture regarding cardiac biomarkers. So that's how we differentiate now. We have two conditions, unstable angina and non-ST elevation in mind, both having similar changes, ST depressions and T inversion. There, if you do troponin I, it will be elevated in non-ST elevation in mind, but not elevated in unstable angina. But if you see a ST elevation, would you do a troponin? Who would do a troponin and who would not do a troponin? Anyone? Now, I believe you all have had the clinical training for 1 week at least, 1 or 2 weeks. Anyone? Would you do or not? Everyone is silent. Tilina? Tilina Pereira. Harushi? Angelika? Yes, Tilina.
Yes, madam. I think we should.
What do you think, Tilina? How long does it take for the troponin to rise? Maybe an unfair question. Have you had that lecture? The cardiac biomarkers lecture? Yes or no? Not sure. Anyone? Not yet. You mean?
Madam, we had earlier, but like not related to the changes in the cardiovascular system.
Not earlier means biochemistry.
Like with the yes, madam.
Ah, right. Oh, don't worry. There's another lecture in this module, if I'm not mistaken. So you will learn that for the troponin I to rise, it will take 6 hours, right? So this ST elevation is an early change, right? So I will come to that. What are the things we need to observe in acute ischemia? So you don't wait for the troponin to rise. 6 hours is a long time for if somebody is having an infarction and if part of the heart is dying, you don't wait till the troponins to go up. If you see ST elevation, you refer for treatment, right? So that's something you have to, engrave in your mind because some doctors even do that mistake. You have ST elevation MI and you are just waiting for the troponin I report. That is not needed because you have clear evidence of infarction, right? So ST segment elevation, how you identify is there is a isoelectrical point and the ST segment is elevated. But how much elevation is significant? Anybody having any idea? So in the chest leads, it need to be at least 2 small squares. And in the inferior leads, I will show you, it's just 1 square elevation is significant. Okay, so please write that up because I didn't include it in the slides. So ST segment elevation, the magnitude of the ST segment elevation to be significant, it has to be 2 small squares in chest leads, so V1 to V6, or 1 small square in inferior leads, right? ST segment depression, also again 2 is the sort of the cutoff, and T inversion, obviously because T inversion, usually T is upper deflation, and if it is inverted, it is significant. Okay. So in order to identify abnormalities, you need to have a good idea what is the normal ECG looks like, right? So normal ECG, if the cardiac axis is normal or on the left side, it's normal cardiac axis, all 3 deflations are positive, right? If it is left, you get 1 being positive, 2 and 3 negative. The 2 and 3 leads, which are there on the right and the inferior, becomes negative because it's shifting. If I go back. So if it is the main axis is shifting towards the left side. So first axis is positive and these 2 are negative, right? But in right axis deviation, on the other hand, you get negative first deflation and positive 2 and 3. Okay, but this is the normal axis, all 3 being positive. Okay, And AVR, the unipolar limb leads, AVR, AVL, and AVF. AVR is a negative. All are negative. P, Q, R, S, T, everything is negative, right? So that is normal, right? So don't go and diagnose T inversions here. Rest of it is all AVL and AVF positive. And the chest leads, the V1 and V2 and sometimes V3 are negative. Why? The heart left has the large muscle bulk and the chest leads, when you're looking from this side, right side, V1, V2, V3, the main electrical current is going away from you, and that is why you get a negative deflation, right? So I hope you have already learned that, and I'm just reiterating. So these are negative, and right somewhere in V3 or V4 we have equivocal, like R and S being similar, and then V5 and V6 it's the positive deflation or QRS complexes that we are seeing. So in a ischemic situation, or when the patient comes with chest pain, now we discussed about this matter of duration. Now we need to have an idea what is the duration from the onset of the infarction, isn't it? Because all our therapy is based on the time duration. So very early on, we see these peak T waves, very tall T waves. Can somebody tell me any other condition that you know of having peak T waves or tall T waves? Anyone?
Yeah.
Hyperkalemia. Huh? Hyperkalemia, no? Hyperkalemia? Hyperpotassium concentration. But with the classical chest pain, if you see very peak T waves, that gives you some warning whether this could be a ST elevation or not. Then that's why if a patient comes with the classic chest pain, you need to repeat ECG every 10 minutes. And within few hours, you get this decrease of ST elevation, ST segment elevation. Initially, it could be upward elevation, and then the classical pattern of ST elevation, huge elevation. If you see this last diagram, that is a very severe infarction, huge ST elevation, right? So that is the kind of progression that you see. But within, many hours to few days, then you have Q waves being formed, very prominent downward deflation, ST segment coming down. Why? Now the whole of the left ventricle, that part is infarcted. It doesn't generate any electrical activity. So it comes to the baseline, right? And later on, weeks on, we see Q wave and a T wave inversion. So this is, if we see this, there's no point in doing angiograms and stenting. Weeks old in mind, right? Although ST segment may be slightly elevated, once you see Q waves being formed, right? We know it's more than few days old or even weeks. So there's no point in probably doing revascularization, doing a stent and getting the blood flow restored, or giving streptokinase or any TPA to thrombolize and restore the circulation, because now the tissue is already infarcted, right? So ECG plays a big role in deciding which patient needs active therapy or urgent referral, because our resources are very, very limited, okay? So remember this pattern of progression of ECG changes in ST elevation MI, and roughly the duration, early to few hours, many hours to weeks. Okay, is this clear for everybody? Yes or no? I hope none has had allergies and collapsed with the injection? Everybody listening? Or I just wanted to ask whether this was clear. This is something important for your clinicals. Is it clear, Satsara?
Yes.
Kalani? Yes, Satsara.
Yes, madam.
Okay, right. So you're welcome to put messages in the chat box if you have any. So ST segment actually corresponds temporally to the transmembrane action potential in phase 2. If you can remember the electrical activity of the cardiac muscle, the phase 2, the plateau phase, is what is represented by the ST segment. So ST segment at baseline indicates the absence of a significant voltage gradient during phase 2 ventricular repolarization, right? So the QRS is the depolarization wave and ST is the plateau phase and there's no voltage gradient, right? So this ventricular repolarization phase does not create any significant voltage gradient. That's why it's isoelectric, right? But the loss of the action potential amplitude in ischemic zone is responsible for this ST segment elevation, right? So ischemic, when the tissue is undergoing ischemia, there are a lot of changes happening, right? A difference in action potential plateau amplitude generates a transmural voltage gradient that manifests as a ST segment elevation. So earlier, non-infarcted tissue or live tissue did not have any voltage gradient, but because now the ischemic tissue is undergoing changes, electrical changes occur, and there is difference in action potential plateau amplitude, which generates a transmural voltage gradient, right? So ideally there should be not any voltage gradient. So that's why it's isoelectric, the early phase 2 plateau phase of ventricular repolarization. But when it is undergoing ischemia, it doesn't undergo ischemia all of a sudden. No, there's a wall thickness. So this change generates a transmural voltage gradient that manifests as a ST segment elevation, right? So if you are to summarize the major abnormalities of membrane polarization associated with acute myocardial infarction, we'll see the defect in infarcted cell versus the current flow and resultant ECG changes. So rapid repolarization is what is indicated by this ST elevation, isn't it? Usually, if it is in the plateau phase, it's isoelectric. But if it is rapidly repolarization, like the T wave being an upward deflation, now the ST segment is also now upwardly deflated, right? So abnormally rapid repolarization after discharge of the infarcted muscle fiber as a result of accelerated opening of potassium channels. So that is the pathophysiology. So it is directed out of the infarct and there is ST segment elevation towards the limb leads, right? Or towards the chest leads. So decrease in the resting membrane potential during diastole because of the loss of intracellular potassium, because it has been already opened. The current is directed inwards and the TQ segment is depressed. In other words, if we go back to the ECG, TQ means this one and the next Q wave, right? So that segment is depressed and that manifests as a ST segment elevation, right? And there's delayed depolarization as well. So repolarization is rapid and depolarization is again delayed. So that also manifests as ST segment elevation. So those are the pathological changes in the electrical current which give rise to this ST segment elevation, right? So if you are to further see the mechanism of ECG changes, it's a model associated with transmural ischemia. This is the ischemic part and recording electrolyte, and this current is moving towards this this voltage difference that we talked about, transmural, and so there is rapid repolarization which manifests as ST elevation. Okay. Another diagram, the injury current and the loss of AP dome or the plateau amplitude. This is what I was referring to, the electrical activity, where the phase 2 repolarization is rapid, and usually there's endocardium to epicardium. That's how the the electrical waveform travels, and that manifests as ST elevation. Okay. So the complete loss of epicardial dome manifests as co-coved ST segment elevation, whereas partial loss of epicardial dome is associated with saddleback type ST elevation, segment elevation. So saddleback is this, right? And coved is this. So how do we correlate with the coronary anatomy? So that is also one of the things we were worried about. Now, first thing is, what are the changes? Second thing is the duration of the change. And the third thing is, how do we correlate with the coronary anatomy? Right? So if we take the chest leads, you know that each of these chest leads are looking at specific segments of the heart, right? V1. So fourth intercostal space, to the right is the septum, and it's classically looking at the septum. Fourth intercostal space, left to the septum, V2, that's also looking at the septum. So if there are septal infarction, V1 and V2 are the leads to look at. Or if we see changes in V1 and V2, you know the septum is infarcting, right? V3 and V4, the anterior leads, anterior chambers of the heart. So directly between V2 and V4, V3 and V4 is the fifth intercostal space of the left mid-clavicular line, right? Anterior chest leads. And V5 and V6 are the lateral chest leads. That's also in the level with the V4 at the left anterior axillary line, and V6 at the level with the V5 at the left maxillary line, right? So ECG changes, when you're interpreting the ECG changes in acute coronary syndrome, first you have to identify. That's why I said the presence of change. You have to know the normal, and you have to identify there's a change, right? And what is the extent? It is a magnitude of the ST elevation, magnitude of the T inversion or ST depression. You need to have an idea. And the severity of the ischemia. Severity, involvement of lot of leads will be indicative of severity, as well as the magnitude of the change, extent, right? And so when we identify the presence of change, we need to then elaborate on what are the changes. Is it ST elevation, or is it ST depression or T inversion? Then we know how to differentiate between unstable angina, non-ST elevation MI, and ST elevation MI, right? And then we look at this diagram to see which territory does the ECG changes belongs to, right? And finally, the duration of changes, whether it's of equal duration. Are all the leads showing ST elevation, or are there some Q waves being formed, whether it was an old infarct, on top of that being another infarction? There are a lot of things to think about. So how do we correlate with this duration of changes? One thing is looking at the ECG. Other important thing, anyone? Dimuthu Fonseca, what do you think? How do we correlate? How do we have get an idea of the duration of the changes? Dimuthu? Dimuthu? Malshi? Anyone? Think. You see some changes. There are Q waves, there are ST elevations. How do we know whether it's an old Q wave infarction or there's a new infarction on top of the old one? How do we know? Can you just tell by looking at the ECG? Surasan, Ravindran? Anyone? No, all are silent. Anyone guess anything? Ayesh? Risni? Tilina? Tilina Pereira? Vibhat Abevik? Yes, Tilina. I can't hear you. Sandali Aloka? I don't know whether y'all are there or not even. Can somebody speak up, please?
Madam, if the R wave is depressed more than 2.5 small square?
Yes, Venura, yes. There are ECG criteria, like Q wave formation and so on, by which you can see whether it's old or not. But what is the other most important thing? The clinical history, right? The patient would say 3 months ago, I was with a severe chest pain, I was admitted. They gave me injection. They took me to a operation theater. They said they put a stent. And today also, I got the same pain. Now, you have to correlate with the history. That is the point that I want to raise. You have to correlate with the history. Only with the ECG changes, you can't diagnose. Okay? Is everybody clear on that? Are you all clear on that? That you have to take a very good clinical history and then look at the ECG? Huh?
Yes, madam.
Okay, please try. So you all are going towards, please practice that. Okay? So in ECG changes in relation to the coronary anatomy, we know that the V2 to V3, so V1, V2 septum, then the 3 and 4 anterior. So V2 could be either looking at the anterior wall or the septal wall. So left anterior descending artery diagonal branch is supplying the anterior wall. If you find ST segment elevation, T wave inversions, or 2R wave progression, you know which territory is affected, which artery, and which section. Similarly, the septum V1 and V2, the anterior descending artery septal branch, right? Same changes from by identified where it is occurring, we know which section is affected, right? Lateral wall, V5 and V6. These are the chest leads. But also the limb lead 1. Can you remember the limb lead 1, which was on the top? And the unipolar limb lead AVL is also looking at the lateral wall, mainly the left ventricle. So left coronary artery circumflex branch is the one which is supplying. And if the ST segment elevations are there in one AVL, V5, V6, you know it's a lateral infarction, right? Inferior, 2, 3 AVF, 2 and 3 limb leads, and unipolar AVF, the foot limb lead, which is right coronary artery, posterior descending branch. Again, changes are same, but where it is occurring is what has changed. Posterior wall. Posterior, what is the chamber? What is the chamber? Posterior. If it is a posterior infarction, what is the chamber involved?
Left atrium.
Left atrium and left ventricle, yes? Coronary artery circumflex branch at the right coronary artery, posterior descending branch, right? So we discussed about what are the changes. the duration of the changes, how we can get an idea, of course, to correlate with the history, severity of the changes, and what it would have on the implication on the treatment. And I'm going to discuss about something called pattern recognition, because we are not, as I said before, we are not looking at each limb lead or each minute change in limb leads, in any one of the leads. We are trying to recognize a pattern, right? So thereby, it's easy for us to diagnose whether it's a lateral MI, posterior MI, inferior MI, or anterior MI, right? And the acute coronary syndrome, we know it is due to a block in the coronary circulation. If we go back to the diagram of the coronary anatomy, at a given time, usually when the patient comes with chest pain, it indicates now there is an impending complete blockade, right? So unstable angina, what is before unstable angina? What is preceding unstable angina?
Stable angina.
Yes, if I write, it's stable angina, right? So stable angina patients will give the history of, I'm walking for 1 kilometer. Always when I walk up to the, whatever the distance, I get this classical chest pain. But if I sit and wait, it goes away and it doesn't progress. So that is stable angina. There is limitation of the blood flow, but that is uniform, right? There's no dynamic change. But in unstable angina, the patients would say, earlier I used to go up to 1 kilometer, but today, when I went up to 500 meters, I started getting chest pain. It didn't go away. Now, even after walking a few steps, I'm getting. So that is unstable angina. That is a dynamic change in the flow with impending ischemia, right? So impending blockade or worsening ischemia, that is unstable angina. There, if you do a ECG, you will get ECG changes such as ST depression or T inversion. And depending on the site, we know whether we cannot diagnose whether it's the left anterior descending circumflex correlating to lateral ischemia or posterior wall or whatever. But if that particular section is already infarcted, but depending on the infarction, it didn't give right to a ST elevation segment, ST elevation MI, but it's a non-ST elevation MI, then you know the changes are same as unstable angina, but if you do a TROP-I, it will be positive, right? In unstable angina, TROP-I is negative. But ST elevation MI is very significant, severe ischemia, it's a complete block. There is marked changes. We saw the duration of changes, how it progresses. That gives us some opportunity to revascularize and save that bit of left ventricle. Okay, so knowing the patterns enable us to look for changes in the relevant leads, and in an emergency, it's easy to diagnose. Right? Can you all have a look at this ECG and tell me which leads are abnormal and if at all, and what are the changes that you can see? Can you all speak up or put it in the chat box? We gave a clue that it's all, there's abnormality. Anyone? Now we are running out of time, also children. If you speak up, that will be easy for you. Is it normal or not?
Not normal, madam.
Okay, what is the change that you see, Tarushi?
There's ST segment elevation in V1, V2, then
V3?
V3.
Yes, V3, yeah. Yes, good. So very extensive, and there's already large Q waves and T waves also inverted. And there are no changes, but AVL, you see a T-wave invasion. So lateral, we don't know whether it's affected because V5, V6 looks normal. So what is the diagnosis? It's an anterior MI. So septum is affected, anterior part of the heart is affected. So V1 to V3, if there are ST segment elevations, and from the other features like Q waves and T wave inversions, we can say it is quite advanced or progressed, right? So if you take a history, you would know this patient would have had chest pain for hours, right? So anterior STEMI. In this ECG, can somebody point out where you can see changes? Anyone? Anyone? Malshi? Malshi, can you tell me where you can see any change?
Madam, ST depression in
Where?
V1, V2,
Yes, agree.
and V3.
Yes. What else? Are there any ST elevations, Malshi? Yes or no? What about lead 1 and AVL? Yeah? So this is the isolation point. Yeah, there's ST elevation, right? So don't always have a look at the entire ECG. There are severe ST depression, widespread, 3 AVF, 2 a little bit. So that is sort of inferior territory. Some ischemia is going on. 1 and AVL, ST elevation. And here also you have ST depressions in 1 to 3. Okay. And what is the diagnosis? Lateral STEMI. V5 and V6, it had just started going up, very tall T waves, but already the corresponding other limb leads, 1 and AVL, there is ST elevation. So this is lateral STEMI. And there are reciprocal changes on the other side. V1 to V3, why would you see ST depression? Because it is looking directly from the opposite side, right? So you're looking from the right side at the infarction which is happening on the lateral side, towards the left, right? So the electrical current is going away. That is why it is depressed. But it is very significant if you see these reciprocal changes to V4 to V6. The opposite reciprocal changes we are seeing V1 to V3, right? So 1 AVL elevation corresponding to lateral. What is this? Where are the abnormalities? So since our time is going on, can you see 2, 3 and AVF ST segment elevations? 2, 3 AVF. 2, 3 AVF belongs to looking at which part of the heart? 2, 3 AVF anywhere foot. So it's inferior. So it's an inferior STEMI. ST elevations in 2, 3 AVF. So in these leads, we are not worried about 2 small squares. Even 1 small square rise, we have to be vigilant in diagnosing inferior STEMI. Do you see the difference? Okay. So what about this? there are ST segment depressions in V2 to V3, V4, V6 as well, right? So one could say these are ST depressions, right? But if you see the ST depressions in these, is there any change? Here, if you, have a look upside down, make it turn upside down, it would look like ST segment elevation, right? This T wave is being diminished, unlike the tall T wave that you saw with the ST depression, right? So that is giving rise to the appearance of a ST segment elevation if you turn the ECG upside down. So that's how we diagnose the posterior STEMI, because 2, 3, 4, 5, we are looking at the heart from the anterior chest wall, but the infarction is happening on the posterior side, right? So it's okay if you don't diagnose a posterior STEMI because that is at the postgraduate level maybe, but anterior, lateral and inferior infarctions are commoner, and you can diagnose with pattern recognition, okay? So the late changes, we already learned the Q wave formation. It takes after some days to weeks. ST segment abnormalities subside. The rib muscles and the scar tissue become electrically silent, and the infarcted area is therefore negative relative to the normal myocardium during systole, and it fails to contribute to its share of posterior to the electrical cardiographic complex. So the common changes include the appearance of a Q wave, deep Q wave, right down, and poor progression of R waves. If we go back to the normal ECG, I told that the R wave becomes positive around V4 and rest of it is positive. But if there are old infarctions, then there are deep Q waves, and this R wave does not have a positive deflation even in the lateral limb leads, lateral chest leads. So that is called the poor R wave progression, and that is indicative of past infection, or it's a late change of MI, right? And I already told about the bundle branch block. So that is also indicative of past infarction, late changes of STEMI. So non-STEMI, we already discussed about T wave inversions, ST depressions, and this is how it would appear. And again, if it is on the lateral leads or inferior leads or anterior leads, we can diagnose the territory. So non-STEMI, there's an opportunity for us to again treat because it's less severe. And if it is unstable angina, not infarcted yet we can save that portion by giving various treatment, which you are going to learn, right? So this is a classic ECG of a non-STEMI with widespread ST segment depressions, 2, 3 ABF, inferior and V3 also, and there are some lateral changes or anterolateral changes, V4, V5 tea inversions, very widespread ischemia. So probably several branches of the coronary anatomy or coronary supply must be affected. Okay, so these were the references, and I would upload this lecture notes and the recording for the rest of the batch to have a look. And I'm going to
Recording stopped.
I'm going to type my email address for everybody to respond with any questions that you have, and the next lecture is on a late evening. I hope all of you could join, and if you all are free, actually, since most of you couldn't join this lecture, I can stay on to answer any questions. Okay, so I'm going to stop the lecture. Okay.